Hello everyone, my name is Shanmels Chua Valdivia and I am going to perform the NGT or nasogastric tube feeding. Definition: nasogastric tube feeding is the instillation of specially prepared nutrients into the stomach through a nasogastric tube. Assessment: assess client's need for internal tube feedings. Auscultate for bowel sounds before feeding, obtain baseline weight and laboratory values, assess client for fluid volume excesses or deficit electrolytes. Verify physician's order for formula, rate and route and frequency, laboratory data, and bedside assessments such as finger stick blood glucose measurement are also ordered by the physician. Objectives: to provide alternate means of ingesting nutrients for the patients with functional gastrointestinal tract, to intervene in pre-existing or impending nutritional depletion of debilation, to provide aggressive management for certain disease conditions, to provide means of nutrition if there is an inability to swallow or an existing obstruction in upper alimentary canal, to provide nutrients for the patient and comatose or semi-conscious state, to provide increased nutrient requirements above or oral consumptions, to provide nutrients for post-operative patients with bowel sounds present. Equipment: disposable feeding bag and tubing or ready-to-hang system, 2 to 50 milligram syringe, stethoscope, pH indicator, prescribed internal feeding, gloves, equipment to obtain blood glucose by finger stick, kidney basin, water, measuring container from which to pour the feeding, and the syringe method is used. Tissue. General considerations are: verify the tube placement before the feeding and establish patency of the tube. Ensure that the client is sitting upright in a chair or in bed and to infuse the feeding slowly. Report any difficulty infusing the feeding or any discomfort voiced by the client. Auscultation is no longer considered as a reliable method for verification of placement of tube because air in tube inadvertently placed in lung. Obtaining GI fluid for pH measurement, large and small bore feeding tubes, bolus and continuous feeding. Flush tube with 30 ml of air, aspirate GI contents. Procedure: explain the procedure. Discussion and explanation help allay anxiety. Encourage patient cooperation. Perform hand hygiene. Hand hygiene deters the spread of microorganisms. Prepare feeding container to administer formula. Have tube feeding at room temperature. Connect tubing to container as needed or prepare ready to hang container. Shake formula container well and fill container and tubing with formula. Cold formula may cause gastric cramping and discomfort because the liquid is not warmed by mouth and esophagus. Tubing must be free of contamination to prevent the bacterial growth. Filling the tubing with formula prevents excess air from entering GI tract. Place client in high Fowler's position or elevate head of bed 30 degrees. Elevated head helps prevent aspiration. Determine tube placement. Aspirate gastric contents to check for gastric residual. Return aspirated content to stomach unless the volume exceeds 150 ml. Measure of pH of aspirate GI contents. Observe the aspirate's appearance. Consider the results from pH testing and the aspirate's appearance together. Presence of a gastric secretions indicates that the end of the tube is stomach, and residual volume indicates if gastric emptying is delayed. Delayed gastric emptying may be reflected by 150 ml or more remaining the client's stomach. Fasting gastric pH is usually equal to the less than 4. It is only frequently greater than 6. In contrast, intestinal aspirates usually have pH equal to or greater than 7. Gastric fluid is usually cloudy and grassy, green or tan, or off-white in color. In contrast, intestinal fluid is usually deep golden yellow and is clearly the gastric contents. An aspirate with low pH and typical gastric fluid color indicates high probability. Initiate feeding. Bolus or intermittent feeding. Pinch proximal end of the feeding tube prevents air from entering client's stomach. Continuous drip method, hand feeding, bag, and tubing on IV pole. Continuous feeding method is designed to deliver prescribed hourly rate of feeding. This method reduces the risk of abdominal discomfort. Advance tube feeding gradually. Tube feedings should be advanced gradually to prevent diarrhea and gastric intolerance to formula. When tube feedings are not being administered or capped or clamped, the proximal end of the feeding tube prevents air from entering stomach between feedings. Administer water via feeding tube as ordered with diluted formula. Provides client with source of water to help maintain fluid and electrolyte balance. Rinse bag and tubing with warm water. Whenever rinsing bag and tubing with warm water clears old tubing feedings and reduces bacterial growth. Measure amount of aspirate every 4 hours. Evaluates tolerance of tube feeding. Monitor finger stick blood glucose every 6 hours until maximum administration rate is reached and maintained for 24 hours. Alert nurse to client's tolerance of glucose. Monitor intake and output of every 24-hour. Intake and output are indications of fluid balance or fluid volume excess or deficit. Weigh client daily until maximum administration rate is reached and maintained for 24 hours. Then weigh client 3 times per week. Weight gain is indicator of improved nutritional status. However, sudden gain of more than 2 lb in 24 hours usually indicates fluid retention. Observe the return of normal laboratory values. Improving laboratory values indicate an improved nutritional status. Evaluation. Patient tolerates feeding well and weight is maintained increased. Appropriate residual is obtained from aspiration of stomach contents. Patient complies the feeding procedure. Intake and output balance is maintained. Nasogastric tube functions efficiently and remains patent. Documentation. Record the amount of type of feeding, client's response to tube feeding, patency of tube, and any side effects. Reports the client's tolerance and adverse effects.